cholesterol and other lipid particles. Chylomicrons are lipoproteins formed on intestinal epithelial cells from dietary fat. ApoB48 is carried on chylomicrons and is necessary for their formation. Chylomicrons transport lipids absorbed from the diet into the systemic circulation by way of the lymphatic system. ApoB100 is carried on VLDL and on LDL. VLDL is synthesized in the liver from triglycerides and cholesterol. Its function is to transport lipids into adipose tissue and muscle. Once it has delivered most of its triglycerides, VLDL becomes LDL, where cholesterol is a predominant lipid. LDL transports cholesterol into peripheral tissue, where ApoB100 binds to LDL receptors, allowing for the unloading of cholesterol into cells. A-beta lipoproteinemia results from a mutation in the gene that codes for the microsomal triglyceride transfer protein, MTP. This protein is essential for the transport of triglycerides and for the assembly of apolipoproteins. The defect in the synthesis and secretion of apolipoprotein B results in impaired intestinal absorption of lipids and very low levels of serum cholesterol, triglycerides, and VLDL. Inability to absorb lipids from the diet results in diarrhea and neurologic manifestations secondary to vitamin E deficiency. Because lipid-soluble vitamins are absorbed with dietary fat and transported by chylomicrons, ABL results in marked lipid-soluble vitamin deficiency. Vitamin E deficiency is particularly severe in ABL. This is believed to be due to the plasma transport mechanism of vitamin E, which requires the presence of beta-lipoproteins. Vitamin E acts as an antioxidant, neutralizing the damaging effects of free radicals on cell membranes. Deficiency of vitamin E results in multiple neuromuscular manifestations, which are characteristic of ABL. Let's identify the clinical manifestations of A-beta lipoproteinemia as our second learning objective. Clinical manifestations of ABL occur early in life, initially in the form of gastrointestinal disturbances. Infants affected by this disorder appear normal at birth, but quickly develop abdominal distension and steatorrhea due to the malabsorption of dietary fats. In steatorrhea, stools are fatty, pale, and fetid. Because of the loss of fat and fat-soluble vitamins in stool, infants exhibit failure to thrive. ABL patients are slow in reaching motor and cognitive developmental milestones. 1/3 of patients suffer from mental retardation. Neurologic manifestations are the result of vitamin E deficiency and include absence of deep tendon reflexes, peripheral neuropathy manifesting as numbness, weakness, tremors, and altered sensation and pain. Loss of proprioception and vibratory sense occurs in the lower extremities. In later stages, cerebellar signs develop, such as ataxia, spastic gait, and dysmetria. Ophthalmologic manifestations usually occur during adolescence. These are related to the deficiency of vitamin A. Retinitis pigmentosa is a form of retinal dystrophy characterized by progressive loss of vision. Patients may initially have loss of night vision, followed by loss of peripheral vision. Blindness usually occurs by the 4th decade of life. Let's discuss the diagnosis of A-beta lipoproteinemia as our third learning objective. The diagnosis of ABL should be suspected in cases of chronic steatorrhea in infants, especially if accompanied by neurologic manifestations. These are not usually present in the early stages of the disease. Workup includes stool analysis in order to exclude bacterial or parasitic infections, as well as other causes of malabsorption. A fasting lipid profile will show the absence of VLDL and LDL. Total cholesterol levels are often below 50 mg per deciliter, and triglyceride levels close to zero. A complete blood count will often show thrombocytopenia, believed to be the result of impaired absorption of vitamin cofactors. Patients suffering from ABL have altered red blood cell morphology, with 40 to 80% acanthocytes uniformly present on peripheral blood smear. This is thought to be due to lipid content alterations in the membrane of red blood cells. Other studies include a chemistry panel and liver function studies in order to exclude systemic illness and hepatic dysfunction. Transaminases are often elevated in patients diagnosed with ABL, although the mechanism for this finding remains unclear. Imaging studies include gastrointestinal ultrasonography. Fundoscopy is indicated in order to assess retinal degeneration. The diagnosis of ABL is made by finding acanthocytes in the peripheral blood smear in the presence of an extremely low total cholesterol plasma level. Diagnosis is confirmed by finding lipid-filled enterocytes on small bowel biopsy. This cellular finding is a result of triglyceride accumulation. The molecular diagnosis of ABL can be done by DNA analysis. Studies have shown more than 30 different mutations which affect the MTP gene, resulting in the disease. The differential diagnosis of ABL includes familial hypobeta-lipoproteinemia, which is a similar but less severe disorder resulting from mutations in the ApoB gene. Because familial hypobeta-lipoproteinemia occurs as a codominant mutation, carriers demonstrate less than 1/2 normal levels of plasma cholesterol and LDL, conferring them a decreased risk of atherosclerosis. In homozygous familial hypobeta-lipoproteinemia, patients have gastrointestinal and neurologic symptoms similar to those seen in ABL. However, their lipoprotein and beta-lipoprotein levels are low, but not entirely absent as in ABL. Additionally, while in ABL all patients uniformly demonstrate acanthocytosis as a hematological finding, in familial hypobeta-lipoproteinemia, patients may or may not have acanthocytes in the peripheral smear. Patients with familial hypobeta-lipoproteinemia have a tendency towards fatty liver disease. Non-familial or secondary hypobeta-lipoproteinemia is related to occult malignancy, liver disease, and malnutrition. Other differentials to be considered include other causes of malabsorption, such as cystic fibrosis, celiac disease, inflammatory bowel disease, and Whipple disease. Neurologic disorders with similar presentation include spinocerebellar degeneration, Friedreich's ataxia, and hereditary sensory motor neuropathies. Let's review the treatment and prognosis of A-beta-lipoproteinemia as our fourth learning objective. There is no treatment for the primary defect in ABL. The condition is managed by supplementing megadoses of lipid-soluble vitamins, particularly vitamin E. Vitamin E supplementation early on in the course of the disease has been shown to delay and improve neurologic symptoms. Supplementation with vitamin A is protective against visual manifestations, such as retinitis pigmentosa. Dietary restriction of triglycerides improves the gastrointestinal disturbances associated with the disease. The prognosis of ABL improves with early treatment. Without vitamin supplementation, the life expectancy of patients is markedly reduced due to the early onset of disability. Let us return to our vignette and apply what we've just discussed. Given this 18-month-old girl's presentation of failure to thrive, chronic steatorrhea, acanthocytosis, extremely low levels of total cholesterol and triglycerides, and the absence of LDL and VLDL, her diagnosis is likely A-beta-lipoproteinemia. What is the molecular defect underlying the mechanism of this disease? Mutations in the microsomal triglyceride transfer protein gene result in defective assembly and secretion of beta-lipoproteins. The deficiency of ApoB100 and ApoB48 in turn leads to impaired lipid absorption, resulting in steatorrhea and vitamin deficiency. The uncorrected deficiencies of vitamins E and A result in neurologic as well as visual manifestations that can ultimately lead to disability.
Notice this older patient's shortness of breath with minimal exertion and swelling of his lower extremities. These are symptoms suggestive of congestive heart failure. Also, his history of hypertension is a risk factor for cardiac disease and CHF. The diagnosis of CHF is also supported by his physical examination. That is, his jugular venous distension and pretibial edema reflect congestion of the systemic capillaries, which is common in right-sided heart failure. Also, the presence of an S3 gallop is related to the rapid filling of the left ventricle during diastole. The anatomic features of his CHF are reflected in other portions of the vignette. For example, on chest X-ray, his enlarged cardiac silhouette, and on echo, his dilated left ventricle are consistent with his left displaced apical impulse identified during auscultation. His left ventricular ejection fraction is well below the normal range of 55 to 65%. This may have been reduced as the result of intrinsic problems with his heart muscle. This clinical correlate has 3 learning objectives, and at the conclusion of this exercise, you should be able to 1. Describe the renin-angiotensin-aldosterone system and the pathophysiology of congestive heart failure. 2. Diagnose CHF based on clinical presentation, physical examination, and imaging studies. 3. Recognize the drugs used in the treatment of CHF that have proven survival benefit and explain their mechanisms of action. We will begin with our first learning objective. Now, effective cardiac performance is dependent in part on the kidney's control of circulating blood volume. In the kidney, secretion of the enzyme renin by the juxtaglomerular cells is the key step in the regulation of fluid and electrolyte homeostasis and blood pressure. There are 3 mechanisms that control renin secretion. The baroreceptors of the juxtaglomerular cells of the afferent arterioles, the sodium concentration at the macula densa in the distal convoluted tubules, and sympathetic innervation of the kidney by the beta-1 adrenergic receptors of the juxtaglomerular cells. Under certain physiologic conditions, like when blood volume is low, the juxtaglomerular cells increase renin secretion. Plasma renin cleaves angiotensinogen to form angiotensin 1, which is then converted to angiotensin 2 by angiotensin converting enzyme, or ACE, in the capillaries of the lungs and other organs. Plasma angiotensin 2 has multiple actions on different vascular and organ systems that ultimately increase extracellular fluid volume and arterial blood pressure. It causes vasoconstriction of renal and systemic arterioles, which raises total peripheral resistance and blood pressure. It also increases secretion of aldosterone from the adrenal cortex, which promotes sodium and fluid reabsorption and excretion of potassium by the renal distal tubules to increase extracellular fluid volume. These actions of angiotensin 2 are mediated by angiotensin 1 receptors. Let us now describe the pathophysiology of CHF. The development of congestive heart failure results from an inciting cardiac injury, for example, chronic hypertension. As a result, the pathologic changes lead to a reduction in stroke volume and cardiac output. These trigger a cascade of neurohumoral responses, particularly by the renin-angiotensin-aldosterone system, leading to systemic vasoconstriction mediated by angiotensin 2 and salt retention mediated by aldosterone. Sodium and water retention accounts for the initial expansion of intravascular volume and the subsequent rise in extravascular volume. This manifests clinically with the appearance of typical signs and symptoms of CHF, such as shortness of breath, elevated jugular venous distension, and dependent edema. We will now address our second learning objective. CHF is a syndrome that develops when the cardiac output becomes insufficient to meet the metabolic demand of the body's tissues and organs. There are nearly 5.2 million people in the United States suffering from CHF. It is more prevalent among African Americans, but among all ethnic groups, the prevalence increases significantly with age. CHF represents approximately 20% of all admissions among patients over 65 years old. Recall that the development of CHF results from an inciting cardiac injury. The most common causes of CHF include myocardial infarction, and other forms of ischemic heart disease, hypertension, cardiomyopathy, and valvular heart disease. The morphologic changes of the heart in CHF depend on the underlying cause. Commonly, the increased mechanical work of the heart due to A. pressure or volume overload, or B. trophic adrenergic signaling causes myocytes to increase in size or hypertrophy. This cumulatively produces an increase in the size and weight of the heart, 2 to 3 times of normal. In response to increases in pressure, such as in hypertension or valvular disease, the ventricles develop pressure overload hypertrophy, which usually causes a concentric increase in wall thickness. In contrast, volume overload hypertrophy is characterized by ventricular dilation with normal wall thickness. Some of the important changes in cardiac hypertrophy, such as myocardial remodeling and fibrosis, occur in response to excess angiotensin II and aldosterone formation. Therapeutic inhibition of these processes provides important health benefits to patients with CHF. As a consequence of these pathologic changes, patients may develop signs and symptoms of congestion and hypoperfusion. These include shortness of breath or dyspnea, typically worse when lying flat, which is called orthopnea. Nocturnal breathlessness and cough, known as cardiac asthma or paroxysmal nocturnal dyspnea. Palpitations, foot and ankle swelling, fatigue, and exercise intolerance. Typical findings on physical examination include tachypnea, rowels or wheezing, a displaced apical impulse, an S3 gallop related to rapid filling of the left ventricle during diastole, an S4 gallop related to reduced left ventricular compliance, pulsus alternans or an alternating strong and weak pulse, jugular venous distension, pulmonary edema, pleural effusions, hepatomegaly, ascites, and lower extremity edema. When diagnosing CHF, a chest X-ray may show enlarged cardiac silhouette and the presence of pulmonary edema or pleural effusions. But echocardiography is more accurate and can delineate the anatomy and function of the cardiac chambers and valves. In particular, the left ventricular ejection fraction may decrease well below normal, which is 55 to 65%. Finally, measurement of plasma B-type natriuretic peptide, or BNP, released by the cardiac ventricles is elevated in CHF. Let's turn our attention to our third learning objective. Pharmacological inhibition of the actions of the renin-angiotensin-aldosterone system is widely used, not only in the treatment of patients with CHF, but also of those with hypertension, pulmonary and systemic edema, diabetic nephropathy, and cirrhosis of the liver. The drugs used are beta blockers, specifically carvedilol and metoprolol, angiotensin-converting enzyme inhibitors, or ACE inhibitors, such as captopril and enalapril, angiotensin receptor blockers, or ARBs, such as losartan, aldosterone receptor antagonists, such as spironolactone, loop diuretics, such as furosemide, ionotropes, such as digoxin. The first 4 classes of drugs, that is, beta blockers, ACE inhibitors, ARBs, and the aldosterone receptor antagonists, are drugs of choice because they have all proven to reduce mortality. Each of the 4 modalities of choice has one major effect. You get improved cardiac output with beta blockers. You get decreased adverse cardiac remodeling with ACE inhibitors and ARBs. You get decreased myocardial fibrosis with the aldosterone blockers. In the diagram of the renin-angiotensin-aldosterone system, these drugs act at the following sites. Beta blockers block the beta-1 receptors on the juxtaglomerular cells, leading to a decrease in renin secretion. ACE inhibitors and ARBs suppress the formation of angiotensin II and its action at the level of the angiotensin I receptor, thereby lowering arterial resistance, increasing cardiac output, and increasing excretion of sodium in the urine or natriuresis. Spironolactone blocks the sodium-retaining action of aldosterone on the renal tubules and reverses the excretion of potassium, thus acting as an effective diuretic. Let's return to our vignette and apply what we've just discussed. What are the mechanisms of action of drugs known to have a survival benefit in patients with this disorder? These drugs act by blocking renal sympathetic activity as seen with beta blockers, blocking the formation or actions of angiotensin II as seen with ACE inhibitors and ARBs, and blocking the action of aldosterone as seen with spironolactone and aldosterone receptor antagonist. Renal tubular acidosis, or RTA, is the result of an inability of the kidney to appropriately acidify the urine. The subsequent accumulation of acid in the body creates a non-anion gap hyperchloremic metabolic acidosis. In this animation, renal physiology will be reviewed, as well as the various types of renal tubular acidosis. Let's zoom in on the kidney, where filtration and reabsorption of important elements takes place. The nephron is the functional unit of the kidney. Let's take a closer look at the proximal convoluted tubule, or PCT, where most of the filtrate from the Bowman's capsule gets reabsorbed back into circulation. Normal ion transport within the proximal tubule will now be reviewed. Here, many of the ions and molecules that are important to the body are reabsorbed, including bicarbonate, sodium, potassium, and chloride, among others. Epithelial cells of the proximal tubule allow sodium to enter the cell and hydrogen to leave the cell through a channel known as the sodium-hydrogen antiport or exchanger, and labeled here as NHE3. This channel is located on the luminal side of a proximal tubule cell, placing it in direct contact with the filtrate after it passes through the Bowman's capsule. Bicarbonate is unable to move from the lumen across the proximal tubule epithelial cells. In the lumen, hydrogen ions bind to bicarbonate to form carbonic acid. Carbonic anhydrase 4 then cleaves carbonic acid to form water and carbon dioxide, which is able to easily diffuse across the membrane into the epithelial cell. Inside the epithelial cell, the opposite occurs. Carbonic anhydrase 2 forms carbonic acid by binding water and carbon dioxide. Carbonic acid will then dissolve to form hydrogen and bicarbonate. Next, hydrogen ions leave the cell through the sodium-hydrogen antiport in exchange for sodium to enter the lumen. Furthermore, bicarbonate is reabsorbed into the blood through sodium bicarbonate cotransport channels, or NBC1, followed by sodium. Thus, for every one hydrogen ion leaving the cell to enter the lumen, one bicarbonate ion is reabsorbed into the blood. Sodium also enters the blood in exchange for potassium via the sodium-potassium ATPase pump. Potassium from the cell freely diffuses through potassium channels into the blood due to a concentration gradient. Now, let's proceed to the next important section of the nephron that affects ion transport, the collecting duct. Principal cells and intercalated cells line the collecting duct. First, let's look at normal ion transport across principal cells of the collecting duct. Aldosterone enters the principal cell and stimulates the sodium channel to increase influx of sodium from the lumen. This creates a negative electrical charge on the side of the lumen. Aldosterone also activates sodium-potassium ATPase, causing it to pump sodium into the blood in exchange for potassium. Drawn by the negative electrical charge in the lumen, potassium will leave the cell to enter the lumen via a potassium pump labeled here as ROMK. Now, let's look at normal ion transport within the intercalated cells of the collecting duct. Inside intercalated cells, aldosterone stimulates hydrogen ATPase, which, along with the negative charge in the collecting duct lumen, causes hydrogen ions to exit intercalated cells into the lumen. Carbonic anhydrase 2 binds water and carbon dioxide to form carbonic acid. Carbonic acid breaks down into hydrogen and bicarbonate. The hydrogen exits through the hydrogen-potassium ATPase in exchange for potassium. The newly formed bicarbonate will be reabsorbed into the blood in exchange for chloride by way of a bicarbonate chloride or anion exchanger channel. Chloride is then reabsorbed back into the blood either passively due to a concentration gradient, or actively as it is pumped back into the blood with potassium via the potassium chloride pump. In the collecting duct lumen, hydrogen ions bind to monohydrogen phosphate to form dihydrogen phosphate. They also bind to ammonia to form ammonium. Both dihydrogen phosphate and ammonium are excreted in the urine. In renal tubular acidosis type 1, the distal nephron is unable to secrete hydrogen ions. As mentioned before, carbonic anhydrase type 2 binds carbon dioxide and water to form carbonic acid. Carbonic acid breaks down into hydrogen and bicarbonate. Diminished hydrogen ATPase activity is the most common cause of RTA type 1, resulting in hydrogen unable to be secreted. Many different disorders can cause diminished hydrogen ATPase activity, including mutation and immunologic injury, which occurs in Sjogren's syndrome. Impaired function of hydrogen-potassium ATPase can also cause RTA type 1. When the pump is impaired, potassium reabsorption is decreased, leading to hypokalemia. Now, let's focus on what happens when the anion exchanger pump fails. Mutation of the anion exchanger pump, which is the chloride bicarbonate pump, leads to decreased bicarbonate reabsorption, causing hypobicarbonatemia and subsequent acidosis. Renal tubular acidosis type 4 is associated with aldosterone deficiency or resistance. Within principal cells, a lack of aldosterone decreases sodium reabsorption, which leads to an increased positive charge in the lumen. Lack of aldosterone will also affect sodium-potassium ATPase, which causes decreased potassium secretion, resulting in hyperkalemia. Within intercalated cells, hypoaldosteronemia and increased positive charge in the lumen leads to decreased hydrogen ion secretion, resulting in acidosis. Renal tubular acidosis type 2. Renal tubular acidosis type 2 results from a defect in bicarbonate reabsorption within the proximal tubule, which leads to urinary bicarbonate wasting. Let's take a closer look at the proximal tubule. This defect can be caused by a dysfunction of the sodium-hydrogen antiporter, which results in a decrease of sodium reabsorption and hydrogen secretion. Decreased hydrogen secretion causes a decrease in bicarbonate reabsorption. Therefore, bicarbonate is wasted in the urine. Let's take another look at the formation of carbonic acid, followed by its breakdown into hydrogen and bicarbonate. Hydrogen exits the cell into the lumen in exchange for sodium, which normally gets reabsorbed with bicarbonate through the sodium bicarbonate cotransporter NBC1. Impairment of this channel, however, can also cause proximal renal tubular acidosis type 2 by decreasing bicarbonate reabsorption, which leads to hypobicarbonatemia and thus acidosis.
Clinical correlate, autoimmune hemolytic anemia. In the immunology lecture, type 2 hypersensitivity is discussed. This type of hypersensitivity is mediated through an antigen-antibody reaction. In autoimmune hemolytic anemia, a form of type 2 hypersensitivity, antibodies are produced against red blood cells, resulting in a shortened lifespan and subsequent hemolysis. Take a moment to read the following clinical vignette. This 28-year-old woman presents complaining of fatigue, dizziness, and palpitations for the past 2 days. She also reports voiding dark-colored urine in the morning. She was diagnosed with lupus 2 years ago and was managed with prednisone, which she admits to not being compliant with. Physical examination shows that she is tachycardic, tachypnic, and jaundiced. These findings could be due to an underlying anemia, the presence of oral ulcerations, and a friction rub on auscultation, indicating pleurisy, are consistent with a flare-up of lupus. The complete blood count and hemoglobin and hematocrit levels confirm the presence of anemia. Reticulocytosis, elevated levels of LDH, and unconjugated bilirubin with decreased levels of haptoglobin point to the presence of hemolytic anemia. Hemoglobin in the urine is consistent with intravascular hemolysis. Spherocytes and schistocytes on peripheral smear suggest immune-mediated hemolysis. The presence of lupus in this patient is very significant. Any chronic inflammatory disease, such as SLE or rheumatoid arthritis, can result in anemia of chronic disease. This anemia develops due to decreased availability of stored iron necessary for erythropoiesis under the influence of excessive inflammatory cytokines. Anemia of chronic disease is microcytic and hypochromic, with a normal iron profile. However, hemolysis present in this patient is not a feature of anemia of chronic disease. Again, this patient is known to have lupus, which has been associated with the development of autoimmune hemolytic anemia. This is mediated through type 2 hypersensitivity reactions as compared to all other manifestations of SLE, which arise due to immune complex deposition or type 3 hypersensitivity. The antibodies causing hemolysis in SLE have high affinity to red blood cells at 37 degrees Celsius, hence they are called warm antibodies. The other types of autoimmune hemolytic anemias involve cold antibodies and usually manifest after a viral or bacterial infection or in the setting of lymphoid malignancies. Cold antibody disease usually presents after exposure to cold because antibodies in this disease function best at lower body temperatures. The resultant antibody reaction and subsequent complement fixation in the peripheral vasculature causes the blood flow in the periphery to become sluggish. This produces cyanosis and may cause pain in the affected limb. As none of these findings are present in this patient, the presence of cold antibody-mediated hemolytic anemia is unlikely. This clinical correlate has 4 learning objectives. 1. Define autoimmune hemolytic anemia and review its pathophysiology. 2. Identify the clinical manifestations of autoimmune hemolytic anemia. 3. Describe the tests used to diagnose autoimmune hemolytic anemia. 4. Discuss the treatment of autoimmune hemolytic anemia. We will begin with our first learning objective, to define autoimmune hemolytic anemia and review its pathophysiology. Autoimmune hemolytic anemia is defined as an immune-mediated injury to red blood cells, resulting in a shortened lifespan and subsequent hemolysis. The autoimmune injury is a type 2 hypersensitivity reaction that is antibody-mediated. Up to 80% of cases of autoimmune hemolytic anemia are mediated by an IgG antibody. This antibody is most reactive to red blood cells at 37 degrees Celsius. For this reason, IgGs are called warm antibodies. Conditions that are associated with IgG-mediated autoimmune hemolytic anemia include malignancies such as chronic lymphocytic leukemia, CLL, rheumatic diseases such as SLE, drugs such as alpha-methyl-dopa. Another type of autoimmune hemolytic anemia is cold antibody-mediated, in which antibodies are more reactive against red blood cells at temperatures less than 37 degrees Celsius, optimally at 0 to 4 degrees Celsius. The clinical significance is that they are non-reactive at normal body temperature. Cold antibody-mediated anemia has been further divided into two subtypes depending on the antibody involved: cold agglutinin disease and paroxysmal cold hemoglobinuria. Cold agglutinin disease is an IgM-mediated hemolysis, whereas paroxysmal cold hemoglobinuria, also known as Doneth-Landsteiner hemolytic anemia, is mediated through IgG antibodies, also called DL antibodies, directed against the P antigen on red blood cells. Cold agglutinin disease occurs in malignancies such as Hodgkin's disease, or following infection with Mycoplasma, Epstein-Barr virus, or HIV. Paroxysmal cold hemoglobinuria has been found to occur after viral infection in children. It is important that paroxysmal cold hemoglobinuria not be confused with paroxysmal nocturnal hemoglobinuria, or PNH. PNH is a hemolytic disease which results due to an acquired defect in one of the anchoring proteins on the membrane of red blood cells. This causes a defective presentation of decay-accelerating factor, CD55, and protectin, CD59, on the red cell membrane. As these normally prevent complement activation, their absence leads to complement-mediated destruction of red blood cells. However, there is no evidence of self-reacting antibodies in PNH as compared to paroxysmal cold hemoglobinuria. It is important to distinguish the types of antibodies involved because of their clinical relevance. Warm autoimmune hemolytic anemia is mediated by autologous IgG antibodies against red blood cells. These antibodies coat circulating red blood cells. When these cross the splenic pulp, they are phagocytosed by macrophages in the cord of Billroth, which have receptors that recognize the Fc portion of the IgGs. Some of these coated red blood cells are completely phagocytosed by macrophages. In some cases, macrophages are only able to internalize a small portion of the RBC membrane, leading to the development of spherocytes. Compared to normal red blood cells, spherocytes are rigid and are easily hemolyzed while passing through capillaries, or are phagocytosed by splenic macrophages. Hemolysis is usually extravascular and occurs in the spleen. If the titer of bound antibody is high enough, intravascular hemolysis can ensue. Plasma protein haptoglobin binds free hemoglobin that results from hemolysis. In cases of severe hemolysis, levels of haptoglobin are not sufficient to bind with all the free hemoglobin. This results in hemoglobinuria, giving urine a very dark color. In cold agglutinin disease, IgM antibodies bind red blood cells at lower than normal body temperatures. The temperature in superficial peripheral vessels is less than the central body temperatures. In cold exposure, circulating IgMs bind to the red blood cells in peripheral vessels, causing them to agglutinate and impede blood circulation. This produces cyanosis. IgM bound to red blood cells also activates complement, a process known as complement fixation. This can cause hemolysis either by direct lysis of cells or by opsonizing them for phagocytosis by liver macrophages. It is important to note that the spleen does not play a role in cold agglutinin disease. This occurs because liver macrophages recognize complement-bound red blood cells as opposed to splenic macrophages. As blood moves centrally and becomes warmer, antibodies dissociate from red blood cells. Once complement is activated, it doesn't require IgM to be attached to red blood cells for their destruction to continue. The antibodies then return to the periphery, where they attach to new red blood cells and activate complement. If this cycle is fast enough, intravascular hemolysis can occur, producing hemoglobinuria. Let's turn to our second learning objective and identify the clinical manifestations of autoimmune hemolytic anemia. The clinical manifestations of autoimmune hemolytic anemia include fatigue, dizziness, tachycardia, dyspnea on exertion, and chest pain, as with all forms of anemia. Jaundice due to excessive indirect bilirubin resulting from degradation of free hemoglobin. Dark urine can appear when the serum free hemoglobin exceeds haptoglobin levels. Gallstones may develop if the hemolysis occurs over a long period of time. Fever and chills can result from very rapid hemolysis. Splenomegaly can result from excessive hemolysis in warm antibody autoimmune hemolytic anemia. Peripheral cyanosis may occur in cold antibody-mediated hemolytic anemia. Let's describe the test used to diagnose autoimmune hemolytic anemia as our third learning objective. Autoimmune hemolytic anemia can be diagnosed using a direct antiglobulin test, also known as the direct Coombs test. In this test, the patient's red blood cells are isolated by centrifugation and then washed to remove leukocytes and other immune components. Antihuman globulin, or Coombs reagent, is then added to the washed red blood cells. The reagent is an antibody against human autoantibodies. If autoantibodies are bound to red blood cells, as in the case of warm autoimmune hemolytic anemia, the antihuman globulin will cross-link these, causing red blood cells to agglutinate. This can be visualized as clumping. Antibodies in cold agglutinin disease dissociate from red blood cells during the washing process, and the Coombs test reagent cannot recognize them. However, if an anti-complement reagent is added, it causes agglutination of red blood cells because complement proteins stay bound even after red blood cells have been washed. Peripheral smear can show spherocytes. Schistocytes, which are fragmented red blood cells, can also be visualized. In addition to the above findings, other laboratory findings common to all hemolytic anemias are found, such as increased LDH, increased indirect bilirubin, decreased serum haptoglobin, reticulocytosis in response to decreased red blood cell mass, and increased urobilinogen in the urine. Let's discuss the treatment of autoimmune hemolytic anemia as our fourth learning objective. In warm autoimmune hemolytic anemia, administration of steroids reduces the rate of hemolysis by an uncertain mechanism. However, it is proposed that steroids reduce autoantibody production and splenic sequestration of red blood cells. Splenectomy is helpful for patients resistant to steroids, as the spleen is the primary site of hemolysis in warm autoimmune hemolytic anemia. Rituximab, a monoclonal antibody against CD20 on B lymphocytes, is also used. Now, in the treatment of cold agglutinin disease, every attempt should be made to keep the body warm, as IgM loses its reactivity to red blood cells at optimal body temperature. Steroids are not used in cold agglutinin disease, as they do not prevent hemolysis. Since hemolysis occurs in the liver, splenectomy is not beneficial. Immunosuppressive drugs, such as cyclophosphamide, can be given to patients with severe hemolysis. Rituximab can also be used, and plasmapheresis can be done for temporary remission of hemolysis. Blood transfusion is reserved for those with severe anemia. When it occurs in response to infections such as mycoplasma, cold agglutinin disease tends to be transient and resolves with supportive therapy. Let us return to our vignette and apply what we've just discussed. This patient, known to have lupus, has recently stopped taking her daily dose of prednisone and presents with signs and symptoms of acute hemolysis. Given this presentation, it is likely that she has autoimmune hemolytic anemia, which is caused by IgG autoantibodies produced against red blood cells. What is most likely to be found on direct antiglobulin testing in this patient? In the direct Coombs test, red blood cells are washed and human antiglobulin, known as Coombs reagent, is added to them. This results in agglutination of red blood cells if autoantibodies are bound to them.
Clinical correlate, osteoporosis. In the anatomy lecture, the role of osteoclasts in the development of osteoporosis was discussed. Osteoclasts carry out bone resorption by breaking down bone matrix, leading to the release of calcium. Take a moment to read the following clinical vignette. This 66-year-old white female presents to the emergency department with severe pain in her left hip and limited mobility in her left lower extremity after a fall. She is unable to bear weight on her affected limb, as demonstrated by her inability to stand. She is 5 foot 4 inches tall and weighs 108 pounds. She has smoked half a pack of cigarettes per day for 35 years. When examined, her left lower extremity is externally rotated and appears to be shorter than the right one. These signs point to a possible fracture of the left hip, which is later confirmed by X-ray to be an intertrochanteric fracture. Intertrochanteric fractures occur on the proximal part of the femur, between the greater and lesser trochanter. They are the most common type of hip fracture, and in general have a good prognosis in the absence of comorbidities. This patient will most likely need orthopedic surgery to place a permanent hip screw and plate. Although the patient's spine does not appear to be compromised, she will need imaging studies of her lumbar spine in order to rule out possible injury, as vertebral fractures are not always clinically obvious. The patient reports having slipped and denies dizziness or confusion before or after the fall. Falls are a major cause of morbidity and mortality in the elderly and must be investigated carefully. Despite the absence of neurologic findings or history of cardiovascular disease, these common causes of falls in the elderly should be ruled out in this patient. This elderly woman likely has bone fragility, as evidenced by a severe fracture resulting from a relatively minor trauma. For this reason, causes of metabolic bone disease must be investigated. Blood tests have been ordered, including a complete blood count and measurement of serum calcium, phosphorus, vitamin D, alkaline phosphatase, and parathyroid hormone, or PTH. These are within normal limits, making conditions such as hyperparathyroidism unlikely. In an absence of urinary symptoms and a known history, chronic kidney disease is also unlikely. Conditions such as metastatic disease of bone and multiple myeloma should be investigated as well. However, given the absence of specific signs and symptoms, malignancy-related bone disease is not likely in this case. The absence of fever and an abnormal white count points away from infectious etiologies such as osteomyelitis. This patient is a postmenopausal, underweight, white female with a history of smoking and a probable positive family history of osteoporosis in her mother. Given this patient's risk factors, the diagnosis of osteoporosis must be considered as the underlying cause of her hip fracture. What is the best screening test for this patient's underlying condition? This clinical correlate has 4 learning objectives. 1. Define osteoporosis. 2. Describe the pathogenesis of osteoporosis. 3. Discuss the diagnosis of osteoporosis. And 4. Review the treatment and prevention of osteoporosis. We will begin by defining osteoporosis as our first learning objective. Osteoporosis is a skeletal disorder characterized by decrease in bone mass and deterioration of the bone's microarchitecture, in spite of normal bone mineralization. The resulting bone fragility leads to increased risk of fractures. Osteoporosis is the most common metabolic bone disorder in the United States. Decreased bone density is characteristic of the disease. In measuring bone density, the mean is considered to be the bone density of an average 30-year-old woman. A bone density of 2.5 or more standard deviations below the mean denotes the presence of osteoporosis. Now, by contrast, osteopenia is a condition of lower than normal bone density that can progress to osteoporosis. In osteopenia, bone density is between 1.5 to 2.5 standard deviations below the mean. Risk factors for osteoporosis include age, usually greater than 50, race, with whites and Asians being affected more than other races, and gender, with a female-to-male ratio of 4:1 overall. An important risk factor for osteoporosis is family history, in particular a history of maternal fractures. Other risk factors include a body weight below 126 pounds. Lifestyle factors such as smoking and alcohol consumption are also known to increase risk. Inactivity is a risk factor, as is strenuous exercise, which in extreme cases results in amenorrhea, such as in female athletes. Osteoporosis can be classified as primary or secondary. Primary or involutional osteoporosis has no identifiable underlying etiology. It can be further classified into type 1, or postmenopausal, and type 2, or senile osteoporosis. In type 1, or postmenopausal osteoporosis, estrogen deficiency causes accelerated bone loss. It occurs most commonly in women between ages 50 and 70. Type 2, or senile osteoporosis, is due to aging. It occurs in both men and women over age 70. By contrast, secondary osteoporosis is caused by an underlying disease, a deficiency state, or medication side effect, and can occur at any age. There are many conditions known to cause secondary osteoporosis. Congenital disorders such as cystic fibrosis, Marfan syndrome, and osteogenesis imperfecta. Endocrine conditions such as hyperparathyroidism and hyperthyroidism, adrenal insufficiency, Cushing syndrome, estrogen deficiency, and pregnancy. Hypogonadic states such as androgen insensitivity, premature menopause, Turner syndrome, and Klinefelter syndrome. Deficiency states such as calcium, magnesium, and vitamin D deficiency. Inflammatory bowel disease such as Crohn's disease may lead to malabsorption and deficiency states that may ultimately cause osteoporosis. Other forms of inflammatory disease linked to osteoporosis are ankylosing spondylitis and rheumatoid arthritis. Many drugs are associated with the development of osteoporosis. Corticosteroids are known to have dose-dependent adverse effects on bone metabolism that lead to osteoporosis with a high incidence of fractures. Other medications are anticonvulsants such as phenytoin and carbamazepine, the anticoagulant heparin, and the mood stabilizer lithium. Neoplastic causes of secondary osteoporosis include leukemia, multiple myeloma, and metastatic disease. Miscellaneous causes include weightlessness, alcoholism, emphysema, and end-stage renal disease. Let's turn our attention to our second learning objective and describe the pathogenesis of osteoporosis. As previously discussed, the pathogenesis of osteoporosis is multifactorial. However, in all types of osteoporosis, the common mechanism is an imbalance between the rates of bone synthesis and bone resorption. In order to understand the pathogenesis of osteoporosis, it is useful to review the metabolism of bone. Osteoblasts and osteoclasts are the main cells involved in bone remodeling, a process by which bone is continuously reshaped and replaced. Osteoblasts form new bone by secreting and mineralizing osteoid. Osteoclasts carry out bone resorption and release calcium into the blood. More than 99% of body calcium is stored in bone. Vitamin D is required for intestinal absorption of calcium. In cases of calcium deficiency, PTH stimulates the breakdown of bone by osteoclasts, leading to release of calcium into the bloodstream. PTH also increases the excretion of phosphorus in the kidney. Calcitonin is a hormone produced in the parafollicular cells of the thyroid. It opposes the actions of PTH by inhibiting osteoclast activity, blocking calcium absorption in the gut, and blocking its reabsorption in the kidney, leading to increased calcium excretion. Where osteoblasts require months to synthesize bone, osteoclasts require only weeks to resorb it. For this reason, a decreased rate of bone formation or an increased rate of bone resorption causing an imbalance in bone remodeling will ultimately lead to bone loss. Both mechanisms are involved in the development of osteoporosis. A third proposed mechanism of osteoporosis is decreased peak bone mass, which is reached at age 25 and is genetically determined in each individual. For this reason, a family history of osteoporosis is an important risk factor for the development of the disease, particularly if there is a maternal history of osteoporosis. Certain hormones and drugs are also known to have an important role in the development of osteoporosis. Estrogen has an important role in regulating bone remodeling. Although the precise mechanism is unknown, it is clear that estrogen has an inhibitory effect on bone resorption. Estrogen also increases levels of 1,25-dihydroxycholecalciferol, the active form of vitamin D, which in turn increases calcium absorption in the gut. Following menopause, the regulatory effect of estrogen on bone resorption is lost. Estrogen deficiency leads to increased osteoclastic activity and rapid loss of bone, particularly in the first 5 years after menopause. Androgens stimulate bone formation. Androgen deficiency occurs in both genders following normal aging and is thought to contribute to bone loss. In contrast, glucocorticoids affect the synthesis of bone by directly impairing the function and differentiation of osteoblasts, as well as accelerating their apoptosis. Glucocorticoids may also cause increased bone resorption due to their effects on the concentration of various hormones, including sex steroids. For this reason, people undergoing chronic treatment with corticosteroids are at risk for developing osteoporosis and have a high incidence of fractures. Smoking is known to cause a 5 to 10% decrease in bone density in both men and women, and has been shown to precipitate early menopause. Pathologic findings in osteoporosis include: in all forms of osteoporosis, mineralization of bone remains normal, in contrast to osteomalacia, in which defective mineralization leads to bone loss. In osteoporosis, there is greater loss of trabecular or spongy bone, which is found on the epiphysis, at the ends of long bone and in the vertebrae. Cortical bone, which is found on the outer aspect of bone and in the diaphysis of long bones, appears thinner and has increased porosity. There are decreased bony spicules, which are deposits of bone matrix aggregates that indicate bone synthesis. The bony spicules that are present appear thinner than normal in osteoporotic bone. Let's discuss the diagnosis of osteoporosis as our third learning objective. The diagnosis of osteoporosis is often made following bone fracture, which is why early screening for the disease is essential in people at risk. Bone fractures are often the first clinical manifestation of osteoporosis and present with acute pain, sometimes in the absence of trauma or underlying pathologies. Vertebral fractures, also known as compression fractures, are the most common overall. Loss of height due to fractures of the vertebral bodies, as well as spinal deformities such as kyphosis, are often seen. 1/3 of vertebral fractures don't manifest clinically. Fractures of the distal radius, or Colles fracture, and vertebral compression fractures are the most common in osteoporosis type 1, which is the postmenopausal type. Hip and vertebral fractures are the most common in osteoporosis type 2, the senile type. The workup of osteoporosis includes a complete blood count, measurement of serum calcium, phosphate, and vitamin D, and thyroid-stimulating hormone levels. Alkaline phosphatase should be measured in order to exclude conditions of bone breakdown, such as multiple myeloma. A 24-hour urinary calcium level is useful to determine the presence of hypercalciuria. Levels of PTH indicate if there is hyperfunction of the parathyroid glands. If androgen deficiency is suspected, levels of testosterone should be measured. All of these tests are usually normal in primary forms of osteoporosis and are done in order to rule out possible underlying etiologies. The diagnosis of osteoporosis is established by performing a dual energy X-ray absorptiometry, or DEXA. This study is used to calculate bone density at the hip and spine, which are at the highest risk of fracture. DEXA scan results are reported as a T-score. A T-score greater or equal to 2.5 standard deviations below the mean indicates osteoporosis. Let's review the treatment and prevention of osteoporosis as our fourth learning objective. Medications used in the treatment of osteoporosis include bisphosphonates, such as alendronate and risendronate. Bisphosphonates are the first-line therapy for osteoporosis. They act by inhibiting osteoclastic activity, thereby decreasing bone resorption. Other first-line drugs include selective estrogen receptor modulators, or SERMs, such as raloxifene. SERMs act by binding to estrogen receptors in selective tissues. Raloxifene acts as an estrogen agonist in bone tissue, thereby increasing bone density and reducing the risk of fractures. Raloxifene acts as an estrogen antagonist in breast and endometrial tissue, thereby limiting the scope of its actions to bone tissue and making it ideal for the treatment of osteoporosis. By contrast, tamoxifen, another SERM, also acts as an estrogen agonist in bone, but its use in the treatment of osteoporosis is not indicated because of its agonist effects on endometrial tissue and the increased risk of endometrial cancer in susceptible women. Because of its antagonistic actions in estrogen receptors found in breast tissue, tamoxifen is indicated in the treatment of hormone-positive breast cancer. As described previously, calcitonin is a hormone that interferes in bone metabolism by directly binding to osteoclasts and inhibiting bone resorption. Although it is approved for the treatment of osteoporosis, calcitonin has a much lower efficacy when compared to bisphosphonates and SERMs, and is therefore not considered first-line therapy. Studies have shown that the use of calcitonin decreases bone pain following a fracture secondary to osteoporosis, but the mechanism behind this effect is unknown. Teriparatide is a recombinant form of PTH. Although in calcium deficiency, PTH stimulates the breakdown of bone, when given intermittently, it acts on osteoblasts rather than osteoclasts. In this way, it stimulates the formation of new bone, thus increasing bone density. Teriparatide is approved for use in postmenopausal osteoporosis and hypogonadal osteoporosis in men. Other modalities in the treatment of osteoporosis include calcium and vitamin D supplementation. An adequate intake of calcium and vitamin D is necessary in order to maintain body stores and protect bone. Physical therapy, including early mobilization, is recommended once a fracture has occurred. The drugs used in the treatment of osteoporosis are also used in its prevention in order to minimize bone density loss. In addition, the prevention of osteoporosis includes lifestyle modifications and screening for early detection. Lifestyle modifications such as smoking cessation and reduced alcohol consumption are recommended in order to prevent bone loss. Weight-bearing exercise is recommended because it increases bone density and has an added benefit if initiated at an age before peak bone density is reached. It is recommended that all women 65 years or older undergo testing of bone density by DEXA scan. In women with increased risk of developing osteoporosis, measurement of bone density is recommended at the age of 60. Although osteopenia can be evident on plain X-ray film, Its use as a screening method for osteoporosis is not recommended because more than 30% of bone must be lost before changes become apparent on film. Let's return to our vignette and apply what we've just discussed. Given this 66-year-old female's presentation of a hip fracture with a likely positive family history of osteoporosis and other risk factors such as smoking and low body weight, she probably has primary osteoporosis type 1, also known as postmenopausal osteoporosis. Now, what is the best screening method for this patient's underlying condition? The best way to screen for osteoporosis is by assessing bone density. This is done through dual energy X-ray absorptiometry, or DEXA scan. DEXA scan results are reported as a T-score. A T-score greater or equal to 2.5 standard deviations below the mean indicates osteoporosis.
Clinical correlate, neuroleptic malignant syndrome. In the pharmacology lecture, medications used in the treatment of Parkinson's disease and psychosis are reviewed. Neuroleptic malignant syndrome, or NMS, is a serious side effect of dopamine-altering medications. Take a moment to read the following clinical vignette. This 79-year-old woman with a history of Alzheimer's disease presents with agitation and paranoia. These behavioral changes are characteristic of this disease. However, because changes in behavior in the elderly may also be triggered by conditions such as infections and drug intoxication, testing of blood, urine, and cerebrospinal fluid, including toxicology screening, is performed. Given that the initial laboratory tests are normal, her agitation and paranoia are most likely due to Alzheimer's neuropsychiatric dysfunction. As the patient becomes more irritable and aggressive, she is administered a dose of haloperidol. Haloperidol is a high-potency medication in the typical group of antipsychotics. Its anti-dopaminergic activity is used to treat delusional disorders. Notice the change in her condition the following morning. Her vital signs are no longer within the normal limits. She becomes febrile and diaphoretic. She also has signs of autonomic instability, which are tachycardia and a blood pressure that fluctuates over the wide range of 95 to 155 systolic and 55 to 90 diastolic. In addition, she exhibits muscular rigidity associated with tremor in all extremities. Her mental status shows acute, fluctuating confusion, also known as delirium. This patient's tetrad of symptoms, which are fever, muscular rigidity, altered mental status, and autonomic instability following parenteral administration of haloperidol, are consistent with neuroleptic malignant syndrome. This rapidly progressive, life-threatening syndrome results from dopamine receptor blockade in the central nervous system and is associated with the use of neuroleptic agents and other drugs. NMS is a diagnosis of exclusion. Other diseases, such as viral encephalitis and heat stroke, may present similarly and should be ruled out before the diagnosis of NMS is established. Furthermore, NMS belongs to a family of drug-related syndromes that manifest as high fever, muscular rigidity, and autonomic dysfunction. These disorders include serotonin syndrome and anesthetic-induced malignant hyperthermia. These syndromes are distinguishable by the causative drug. This clinical correlate has 4 learning objectives. 1. Define NMS and discuss its pathophysiology. 2. Identify the clinical manifestations of NMS. 3. Describe the diagnostic test for NMS. And 4. Review the treatment of NMS. We will begin with the first learning objective. Define NMS and discuss its pathophysiology. NMS is a life-threatening neurologic emergency associated with the use of neuroleptic agents and is characterized by the tetrad of fever, which is usually high, muscular rigidity, change in mental status, and autonomic instability. NMS is most commonly seen with the use of the typical high-potency neuroleptics, such as haloperidol and fluphenazine. However, low-potency typical neuroleptics, such as chlorpromazine and thioridazine, and the newer atypical neuroleptics, such as clozapine, olanzapine, and risperidone, have also been implicated in NMS. NMS is also seen in patients treated with antiemetic drugs, such as metoclopramide, a dopamine D2 receptor antagonist, and promethazine, a histamine H1 antagonist, and weak dopamine antagonist. NMS has been reported in patients treated for Parkinson's disease when withdrawing L-DOPA or dopamine agonist therapy, reducing the dose, or switching from one drug to another. The exact cause of neuroleptic malignant syndrome is unknown. Because of the class of drugs associated with NMS, most theories of its pathogenesis have focused on dopamine receptor blockade in the central nervous system. For instance, blockade of the nigrostriatal dopamine pathways may cause Parkinsonian symptoms of rigidity and tremor. Also, dopamine receptor blockade in the hypothalamus may cause hyperthermia and other signs of autonomic dysfunction, such as fluctuations in blood pressure and heart rate. An alternative theory is that muscle rigidity represents a primary effect on the skeletal muscle system, perhaps from a direct toxic effect by neuroleptics on muscle cells, or from a primary skeletal muscle defect. Familial clusters of NMS suggest a genetic predisposition to this disorder. For instance, a specific allele of the dopamine D2 receptor gene is overrepresented in NMS patients. As mentioned before, NMS is one of the drug-related syndromes characterized by high fever, muscular rigidity, and autonomic dysfunction. These syndromes also include serotonin syndrome, associated with the use of selected serotonin reuptake inhibitors, or SSRIs, monoamine oxidase inhibitors, and triptans, such as sumatriptan. Also, malignant hyperthermia, a rare genetic disorder associated with the use of depolarizing muscle relaxant succinylcholine, and halogenated anesthetics, such as halothane. The incidence of NMS can be up to 3% among patients taking neuroleptic drugs. Most patients with NMS are young adults, but the syndrome has been described in all age groups. Men are affected twice as much as women. Let's now focus on the second learning objective and identify the clinical manifestations of NMS. The symptoms of neuroleptic malignant syndrome usually develop during the first 2 weeks of neuroleptic therapy. It can occur after a single dose or after treatment with the same dose of the same agent for many years. Risk factors for NMS include recent or rapid dose increase, a switch from one neuroleptic drug to another, and parenteral administration. In most patients, the tetrad of symptoms evolves over 1 to 3 days as follows. They begin with mental status changes, which usually consist of agitated delirium with confusion rather than psychosis. These symptoms can evolve to catatonic signs, mutism, stupor, and eventually coma. These are followed by generalized muscular rigidity, accompanied by tremor. Patients may also have dysarthria, dysphagia, and sialorrhea, an excessive secretion of saliva. Hyperthermia, or body temperatures above 38.4 degrees Celsius, is typical of NMS. Higher temperatures of 40 degrees to 41.5 degrees Celsius are considered hyperpyrexia and are life-threatening. Temperatures of this magnitude occur in 1/3 of patients. Finally, autonomic instability is characterized by tachycardia, tachypnea, and fluctuating blood pressure. Dysrhythmia and profuse diaphoresis may also occur. A mnemonic useful to remember the clinical features of neuroleptic malignant syndrome is fever, which is fever, encephalopathy, vitals, which are unstable, elevated creatine kinase, and rigidity of muscles. Let's turn our attention to our third learning objective and describe the diagnostic test for NMS. As previously mentioned, the diagnosis of NMS is that of exclusion. It should be suspected when 2 major criteria appear in the setting of neuroleptic use, or dopamine withdrawal. These are fever higher than 38 degrees Celsius, or 100.4 degrees Fahrenheit, and muscle rigidity. In addition, at least 2 minor criteria must also be present. These include altered mental status, tachycardia, unstable blood pressure, diaphoresis and tremor, elevated creatine kinase, and leukocytosis. Laboratory tests serve to rule out other conditions in the differential diagnosis, such as viral encephalitis, heat stroke, and other drug-induced syndromes. They also help in evaluating the common metabolic sequelae of NMS. Findings of laboratory tests in NMS include elevated serum creatine kinase, or CK, from muscle damage and rhabdomyolysis. CK levels greater than 1,000 are typical of NMS. They can be as high as 100,000, and the degree of CK elevation correlates with the disease severity and prognosis. Myoglobinuria results from muscle damage and can lead to renal failure, hyperkalemia and metabolic acidosis, hypocalcemia, hypomagnesemia, leukocytosis with a left shift, and mild elevations of liver transaminases, alkaline phosphatase, and lactate dehydrogenase. Let's turn to our fourth learning objective and review the treatment of NMS. Removal of the causative agent, meaning the neuroleptic or antiemetic drug, is the single most important step. However, if the cause of NMS is discontinuation of dopaminergic therapy in Parkinson's disease, that medication should be reinstituted. Supportive care is essential in NMS. Maintain cardiovascular stability using measures like mechanical ventilation, antiarrhythmic agents, or pacemakers as needed. Administer IV fluids to compensate for fluid loss from fever and diaphoresis. Alkalinize the urine to prevent renal failure if serum CK is very high. Lower the body temperature using cooling blankets and antipyretic medications. Control agitation using lorazepam or clonazepam. Specific medications used in the treatment of NMS include dantrolene, a direct-acting skeletal muscle relaxant, which is also used in the management of anesthetic-induced malignant hyperthermia. Bromocriptine, a centrally active dopamine D2 agonist. And amantadine, a dopaminergic and anticholinergic drug. Most episodes of NMS resolve within 2 weeks. Most patients recover without neurologic complications. The mortality rate of NMS is estimated to be between 10 to 20%. It results directly from the autonomic instability of this disease and from systemic complications, such as myoglobinuria and renal failure. Let's return to our vignette and apply what we've just discussed. Based upon her abrupt change in mental status, hyperthermia, generalized muscle rigidity, and autonomic instability, this patient suffers from neuroleptic malignant syndrome, triggered by the recent administration of the high-potency neuroleptic haloperidol. Now, what is the mechanism of action of dantrolene, a medication used in the management of this syndrome? Dantrolene decreases skeletal muscle contractility by blocking calcium release from the sarcoplasmic reticulum through binding to ryanodine receptors. The muscular relaxation which results also helps in resolving the hyperthermia generated by the muscular rigidity. Besides NMS, dantrolene is used in the management of malignant hyperthermia.
Clinical correlate, Alzheimer's disease. In the anatomy lecture, the role of the hippocampus in learning and memory is discussed. Neuronal degeneration involving the hippocampus can result in impairment of memory and severe loss of cognitive ability. Take a moment to read the following clinical vignette. This patient presents with progressive memory loss occurring over the span of several years. Although initially limited to recent events, his memory impairment is now affecting his ability to remember personal information, such as his address and the names of his grandchildren. He has been experiencing difficulty remembering words when he speaks, a language alteration referred to as verbal disfluency. Most recently, he had trouble dressing himself.
a form of apraxia. When examined, he shows no focal neurologic deficits or gait disorders, but is disoriented to time. When approaching this patient, the time frame of his presentation must be taken into account. His symptoms have developed over the course of many years, which excludes acute etiologies of mental status alteration such as delirium, which is a transient disorder of cognition that typically manifests with neuropsychiatric abnormalities and is usually reversible. The presence of chronic cognitive deficits such as progressive memory impairment in an elderly person is suggestive of dementia. This clinical correlate has 5 learning objectives. 1. Discuss the differential diagnosis of dementia. 2. Identify the clinical manifestations of Alzheimer's disease. 3. Discuss the diagnosis of Alzheimer's disease. 4. Describe the pathologic features of Alzheimer's disease. 5. Review the mechanism of action of drugs used in the management of Alzheimer's disease. We will begin by discussing the differential diagnosis of dementia as our first learning objective. Dementia is defined as the loss of cognitive ability severe enough to represent a decline from a previous level of functioning. The etiologies of dementia are varied and share many presenting signs and symptoms. For this reason, it becomes necessary to differentiate between the types of dementia in order to reach the correct diagnosis. In addition to this man's cognitive deficiency, other symptoms must be sought and several etiologies explored. Dementia can be classified as reversible or irreversible. We will begin our review by discussing the irreversible causes of dementia. Now, vascular dementia is characterized by cognitive decline in the setting of cerebral vascular disease. It's the second leading cause of dementia in the United States. Vascular dementia must be suspected in the presence of long-standing hypertension or diabetes mellitus, conditions known to cause damage to blood vessels. Multiple SMOLEs demonstrate focal atrophy of the frontal and temporal lobes on brain CT or MRI. Frontotemporal dementia is due to deposition of tau protein in the brain in what are known as PIC bodies. This disorder most commonly affects males past the age of 60, as in the case of our patient. However, in frontotemporal dementia, language and behavior become abnormal first, and memory is usually preserved until later stages of the disease. Although this patient appears to have a language deficit, his initial presentation is slowly progressive memory loss, and he doesn't appear to have behavioral abnormalities. Lewy body dementia consists of dementia in the presence of Parkinsonian signs such as resting tremor and shuffling gait. Our patient has a normal gait and no focal neurologic alterations. Lewy body dementia is characterized by fluctuations in cognitive function with periods of alertness and attention. In addition, visual hallucinations are present in more than 75% of cases. Huntington's disease is an autosomal dominant degenerative disorder of adult onset. In the absence of movement disorders, neuropsychiatric manifestations, and positive family history, this patient's cognitive deficiency is unlikely to be due to Huntington's disease. A negative RPR in the absence of focal neurologic deficits excludes the possibility of neurosyphilis. The workup of dementia should include testing for HIV in the presence of risk factors for AIDS dementia. The absence of a high white blood cell count and signs of infection, in particular meningeal signs, makes chronic meningitis highly unlikely. Now, a rare cause of dementia is Creutzfeldt-Jakob disease, a spongiform encephalopathy characterized by rapidly progressive dementia following infection with prion proteins. Our patient has slowly progressive dementia, making this an improbable diagnosis. Other causes of dementia are those known as reversible causes. These can be related to alcohol and medication intake or metabolic disorders such as vitamin B12 deficiency, thyroid disease, hyponatremia, hypercalcemia, and hepatic and renal dysfunction. Detection and subsequent correction of these conditions may lead to reversal of dementia symptoms, making their early diagnosis critically important. This patient has no history or signs of alcoholism and is not on any medications. Other than showing some irritation during the medical interview, he does not appear to have alterations in mood or other signs of depression. His vitamin B12, thyroid hormone, and electrolyte levels are normal, making dementia related to metabolic disorders improbable. Another cause of reversible dementia is normal pressure hydrocephalus, a condition which presents most commonly in elderly men and is characterized by the clinical triad of dementia, gait disturbances, and urinary incontinence. If this was the patient's diagnosis, we would expect to find enlarged cerebral ventricles on imaging studies. The patient in the vignette is a 66-year-old male with no previous history of illness and with slowly progressive memory loss that has worsened over a span of several years. He has developed language deficits as demonstrated by his difficulties in speech. Most recently, he has developed apraxia, as demonstrated by his difficulty in dressing himself. Rather than show alarm at his symptoms, he appears to be unconcerned and slightly irritable. In the case of any elderly patient with cognitive deficits, the possibility of Alzheimer's disease must be investigated. Now, Alzheimer's disease is a neurodegenerative disorder of unknown cause which primarily presents in patients over the age of 65. It is the most common cause of dementia, accounting for over 70% of cases in the United States. Let's identify the clinical manifestations of Alzheimer's disease as our second learning objective. The first clinical manifestation of Alzheimer's disease is typically memory impairment in the form of anterograde episodic amnesia. The pattern of memory impairment characteristic for this disease is early loss of recent memory, which is mediated by the hippocampus. Immediate and distant memory, as well as procedural memory, are preserved until later stages of the disease. Other forms of cognitive deficit typically appear following the development of memory impairment. Language and visual spatial skills are the first to be affected, with behavioral and executive function anomalies appearing later. Apraxia can manifest as ability to perform learned motor tasks and usually appears later in the course of the disease. Executive dysfunction may appear in the form of poor judgment, poor planning, or poor insight. Anosognosia, or loss of insight into one's own disorder, is characteristic of Alzheimer's disease. It is common for patients to trivialize the severity of their condition or to attempt to justify the deficits when faced with them. In this context, it is important to interview a spouse, family member, or caretaker in order to obtain a complete picture of the patient's cognitive dysfunction, as well as to verify facts given by the patient. Neuropsychiatric manifestations are common in later stages of the disease. Changes in personality, as well as aggression, agitation, and psychosis may appear during the final stages. In addition, 30% of patients diagnosed with Alzheimer's disease suffer from depression. Focal neurologic deficits may appear during the end stage of Alzheimer's disease. Should they appear earlier, focal neurologic deficits suggest an alternate diagnosis. Let's discuss the diagnosis of Alzheimer's disease as our third learning objective. Because there is no diagnostic test for Alzheimer's disease, the diagnosis must be made clinically once all other causes of dementia have been excluded. Exclusion tests include a complete blood count, an electrolyte panel, as well as quantification of levels of thyroid hormone, liver enzymes, and vitamin B12. The possibility of viral or bacterial infection must be explored by excluding neurosyphilis, HIV infection, and chronic meningitis as possible etiologies. Neuroimaging studies such as brain CT or brain MRI must be done in order to exclude other causes of dementia. The diagnosis of Alzheimer's disease is usually confirmed post-mortem, following autopsy and histopathologic examination of the patient's brain tissue. Let's turn our attention to our fourth learning objective and describe the pathologic features of Alzheimer's disease. The pathogenesis of Alzheimer's disease is unknown. Microscopic findings that are characteristic for Alzheimer's disease are not pathognomonic for it. These consist of neurofibrillary tangles and senile plaques, also known as neuritic plaques, which can on occasion be found in other forms of neurodegenerative disorders. Neurofibrillary tangles are made of phosphorylated tau protein. Tau protein is a stabilizer of microtubules found in neurons. When phosphorylated, it forms insoluble intraneuronal inclusions that interfere with proper functioning and lead to neuronal degeneration. In Alzheimer's disease, neurofibrillary tangles are most prominent in the hippocampal region. Neurofibrillary tangle count strongly correlates with disease severity of Alzheimer's disease. Studies suggest that mutations in certain genes could be responsible for the increased deposition of amyloid protein in Alzheimer's disease. These genes include amyloid precursor protein gene, found on chromosome 21, the presenilin 1 gene, found on chromosome 14, and the presenilin 2 gene, found on chromosome 1. The role of chromosome 21 in the production of amyloid precursor protein has been speculated to contribute to the high prevalence of Alzheimer's disease in people with trisomy 21 or Down syndrome. Down syndrome patients are known to develop Alzheimer's disease in their 40s, 15 to 20 years before the onset of the disease in the general population. Other microscopic findings in Alzheimer's disease include granulovacuolar degeneration of neurons and amyloid angiopathy of small to medium-sized brain vessels. Macroscopically, there is evidence of diffuse cerebral and/or cortical atrophy. Studies suggest that the presence of hippocampal atrophy is highly indicative of Alzheimer's disease, but this measurement is not routinely done in the workup of the disease. Let's review the mechanism of action of drugs used in the management of Alzheimer's disease as our fifth learning objective. There is no cure for Alzheimer's disease, but early treatment with cholinesterase inhibitors has been shown to slow its progression. Cholinesterase inhibitors such as donepezil belong to the drugs classified as indirect acting cholinomimetics and as such prevent the breakdown of acetylcholine in the synaptic cleft. Acetylcholine is a neurotransmitter involved in synaptic plasticity. Now, synaptic plasticity is a characteristic of neurons that allows for synapses to change, thereby allowing for learning and memory. It's known that patients with Alzheimer's disease have a marked reduction in the activity of choline acetyltransferase, an enzyme necessary for the synthesis of acetylcholine in the cerebral cortex and hippocampus. By increasing the amount of acetylcholine available in neural junctions, cholinesterase inhibitors are thought to slow the progression of neuronal degeneration. Another type of drug used in the treatment of Alzheimer's disease is the N-methyl D-aspartate, or NMDA receptor antagonist known as memantine. The NMDA receptor is involved in learning and memory and is found abundantly within hippocampal and cortical neurons. Glutamate is the main excitatory neurotransmitter acting on these neurons. It activates the NMDA receptor by increasing the flow of cations through non-selective channels. Excessive stimulation of the NMDA receptor by glutamate can result in neurotoxicity. Memantine is thought to block excessive activity of the NMDA receptor while preserving its normal functions, thus exerting a neuroprotective effect. Memantine is often used in combination with cholinesterase inhibitors. Antidepressants, valproic acid, and other mood stabilizers can also prove useful in the treatment of Alzheimer's disease. Let's return to our vignette and apply what we've just discussed. Given a 66-year-old male presentation of progressive memory impairment, the onset of apraxia and language alterations, and the absence of a significant medical history or positive findings on physical exam and lab work, it is likely that he has Alzheimer's disease. What will most likely be found on this patient's brain CT or MRI? Brain CT or MRI will most likely show diffuse cortical and/or cerebral atrophy in a patient with Alzheimer's disease. Although not routinely used as a marker, decreased hippocampal volume can also be found. Here are two MRI transaxial cuts of the brain. On the left is a brain of normal aging, while on the right is the brain of a patient of similar age showing cerebral atrophy in a pattern consistent with Alzheimer's disease. These imaging techniques are not diagnostic of Alzheimer's disease, but are useful in excluding other pathologies that could be responsible for the patient's symptoms.
In this animation, we will review the physiology of a cardiac action potential. We will also highlight the effects of different antiarrhythmic drugs. Let's zoom in on the heart. The heart is a beating muscle. Each beat is stimulated by electrical signals that pass through the myocardium. The primary pacemaker of the heart is the sinoatrial SA node, located at the upper border of the right atrium. Action potentials originate in the SA node, and then spread through the two atria, causing them to contract. Once they reach the atrioventricular node, they continue down the bundle of His, which divides within the interventricular septum into right and left bundle branches. From the apex, action potentials are then carried by Purkinje fibers to the ventricular walls. Let's take a closer look at the myocardium to show the events occurring at the cell membrane level. Under resting conditions, the inner surface of the cell membrane is negatively charged, whereas the outer surface is positively charged. This difference in electrical charge across the membrane is referred to as the resting membrane potential. We will now review the action potential of a ventricular myocyte, a fast response type of muscle. The action potential of a ventricular myocyte occurs in 5 phases, numbered 0 to 4. Phase 4 is the resting membrane potential. It's about -85 to -95 millivolts in normal cardiac muscle, and is the membrane potential when the cell is not being stimulated. Let's take a look at the cell membrane during phase 4. The membrane potential at rest is largely determined by potassium permeability, with the inward rectifying channel, labeled as IK1, being the predominant open channel during this phase. Sodium-potassium ATPase pumps help maintain the electrical gradient across the membrane. For every 2 potassium ions these pumps transport inside the cell, 3 sodium ions exit the cell. Once electrically stimulated, a myocyte proceeds to phase 0. Phase 0 is the rapid depolarization phase. This phase is the result of fast sodium channels opening. This causes a rapid influx of sodium that induces a reversal of transmembrane voltage. The inner surface now becomes positively charged, and the outer surface negatively charged. We will now proceed to phase 1. Phase 1 consists of slight repolarization. This is due to the inactivation of fast sodium channels and a transient rapid efflux of potassium. Phase 2 is the plateau phase of the cardiac action potential. It is sustained by a balance between slow inward movement of calcium through L-type calcium channels and an outward movement of potassium through slow delayed rectifier potassium channels, labeled here as IK. Phase 3 is the repolarization of the action potential. During phase 3, the L-type calcium channels close, while the slow delayed rectifying potassium channels remain open. Meanwhile, the opening of more inwardly rectifying potassium channels, IK1, allows efflux of potassium, which leads to a negative change in membrane potential. This net outwardly positive current causes the cell to repolarize. The delayed rectifier potassium channels, or IK, closes when the membrane potential is restored to about -80 to -85 millivolts, which is represented in the lower window by the green dot. Phase 4 is re-established due to rectifying potassium channels, IK1, remaining open to allow potassium to leave the cell. The action potential of slow response fibers will now be reviewed. These slow response fibers are found primarily in the sinoatrial and atrioventricular nodal fibers. This graph illustrates the phases of the action potential within the SA node. The SA node is the primary pacemaker within the heart. Since slow response fibers lack functioning fast channels, they depolarize slower, causing a slower conduction of the action potential across the SA nodal fibers. These cells have no true resting potential. Instead, they generate regular spontaneous action potentials. Sinoatrial nodal action potentials are divided into 3 phases. Phase 4 starts at the end of repolarization, when the membrane potential is at its most negative, about -60 millivolts. Let's visualize what happens at the cell membrane level during this phase, which is also represented graphically in the small window. Funny channels, labeled here as IF, open to allow the influx of sodium. This reverses the membrane potential. Therefore, this reversal of transmembrane voltage causes the cell to reach its threshold for spontaneous depolarization. Let's proceed to the next phase. Phase 0 is the depolarization phase of the action potential. It is caused by a net influx of calcium via the L-type calcium channels. This is followed by repolarization within phase 3. During this phase, a rapid efflux of potassium occurs via delayed rectifying potassium channels, IK. Once the cell is completely repolarized at about -60 millivolts, as seen on the graph, the cycle repeats spontaneously. Antiarrhythmic drugs are used to restore normal rhythm and conduction. They directly or indirectly alter membrane ion conductance, thus altering the physiology of cardiac action potentials. We will first review the Class 1 antiarrhythmic drugs. Let's take a closer look at the ventricular wall and zoom in on a cardiac cell. Sodium channels open during phase 0 to allow influx of sodium into the cell, resulting in depolarization. Class 1 antiarrhythmic drugs are sodium channel blockers. They bind to and block the fast sodium channels. The steep slope of phase 0 depends on the rapid influx of sodium through fast sodium channels. Blocking these channels thus decreases the slope of phase 0. The amplitude of the action potential is therefore also decreased. In addition to decreasing the slope of phase 0, sodium channel blockers alter the duration of the action potential, and thus the effective refractory period, or ERP. This is the period of time when a new action potential cannot be initiated. Class 1 drugs can be divided into 3 subgroups, each with a different effect on the effective refractory period. Class 1A drugs, such as quinidine and procainamide, increase the effective refractory period. Class 1B drugs, such as lidocaine, decrease the effective refractory period. Class 1C drugs, such as flecainide, have no effect on the effective refractory period. Let's now proceed to the next class of antiarrhythmic drugs. Class 2 antiarrhythmic drugs. Let's take a closer look at the ventricular wall and zoom in on a myocyte to show the action of the Class 2 drugs. Under normal conditions, norepinephrine binds to beta-1 adrenoreceptors on myocytes. Beta receptors are G protein receptors, coupled to GS proteins, which activate adenyl cyclase to convert ATP into cyclic AMP. Cyclic AMP then activates protein kinase A, which then phosphorylates L-type calcium channels. This causes them to open and increase calcium entry into the cell from T-tubules. The calcium that enters the cell attaches to ryanodine receptors on the sarcoplasmic reticulum, causing the release of stored calcium. Calcium ions then diffuse from the sarcoplasmic reticulum into the sarcoplasm, ready to bind troponin of myofibrils. These events contribute to increased contractility of the heart, also known as inotropy. Class II agents are beta blockers, such as atenolol, propranolol, and metoprolol. They act by binding to beta-1 adrenergic receptors, blocking norepinephrine, and thus inhibiting normal sympathetic activity on the heart. Therefore, beta blockers decrease heart rate, contractility, and conduction velocity. Let's proceed to the next class of antiarrhythmic drugs. Class III antiarrhythmic drugs, such as amiodarone, are potassium channel blockers. By blocking these channels, they prevent the efflux of potassium during repolarization. This graph illustrates the effect of Class III drugs. Class III drugs prolong phase 3 without altering phase 0, thereby prolonging the effective refractory period. Class IV antiarrhythmic drugs, such as verapamil and diltiazem, are slow calcium channel blockers. By blocking these channels, these drugs decrease the influx of calcium, thus slowing the rate of spontaneous depolarization during phase 0 of slow response fibers, such as SA and AV nodal fibers. Respiration. Respiration is the process of gas exchange that takes place within the lungs between the body and the atmosphere. The mechanics of breathing are central to respiration. Movement of the thoracic cavity causes expansion of the lungs during inspiration and deflation of the lungs during expiration. The physics of respiration are supported by Boyle's law, which states that changes in pressure are inversely proportional to changes in volume within the thoracic cavity. Thus, when volume is decreased, pressure is increased. Let's focus on the movement of intercostal muscles during respiration. During inspiration, intercostal muscles contract, causing the ribs to elevate. This causes the anterior-posterior dimensions of the chest to increase. Simultaneously, the diaphragm contracts, increasing the vertical dimensions of the chest. Together, these events result in expansion of lung volume, and thus a corresponding decrease in intrathoracic pressure. This decrease in intrathoracic pressure allows air from the atmosphere to enter the lungs until equilibrium is reached. During expiration, intercostal muscles and the diaphragm relax, leading to recoil in the thoracic cavity. This results in both a decrease in lung volume and a corresponding increase in pressure, which leads to air within the lungs being expelled. With this in mind, let's take a closer look at the mechanics of respiration and zoom in on the alveoli. Alveoli of the lungs are surrounded by capillaries and contain millions of cells where gas exchange takes place. Pay attention to the changes to the alveoli. During inspiration, alveoli inflate, and in expiration, they deflate. As we zoom in on the alveoli, we can see these changes more closely. When air from the outside, or atmospheric air, enters the alveoli during inspiration, oxygen moves from the alveoli to the capillaries by the process of diffusion. At the same time, carbon dioxide diffuses from the capillaries to the alveoli and is exhaled during expiration. Before inspiration, alveolar pressure is equal to the atmospheric pressure, which is 0. At this point, there is no movement of air in or out of the lungs. During inspiration, the diaphragm and the intercostal muscles contract, increasing thoracic volume. As the lungs expand, alveolar volume increases, and alveolar pressure decreases. At this point, alveolar pressure, which is -1, is less than atmospheric pressure. This difference in pressure causes air to flow into the lungs. At the end of inspiration, inflow of air returns alveolar pressure towards 0. When it reaches 0, air flow stops. Then, during expiration, the opposite takes place. The diaphragm and intercostal muscles relax, causing the lungs to deflate. This decrease in volume within the thoracic cavity results in an increase in pressure. At this point, alveolar pressure, which is now 1, is more than atmospheric pressure, and thus air proceeds to flow out of the lungs. The outflow of air returns alveolar pressure towards 0, at which point the airflow stops. In summary, it is a difference in pressure between the lungs and the atmosphere that drives the flow of air. Now that we've discussed the normal mechanics of respiration, let's turn our attention to restrictive diseases. In restrictive pulmonary diseases, such as fibrosis, lung expansion is limited. The normal maximum expansion of the lungs is represented here by dotted green lines. It is evident that, in this disease, the lungs are not able to reach their normal capacity. Without proper expansion, the lungs cannot fully increase in volume. As a result, without a sufficient decrease in pressure, the normal amount of air cannot enter the lungs. Therefore, patients with restrictive pulmonary disease have problems with inspiration. Obstructive disease can also affect normal lung function. Airway resistance is represented here by dotted blue lines in the lower right. In obstructive pulmonary diseases, such as emphysema or chronic bronchitis, airway resistance is increased. This means that the lungs cannot fully deflate. Without proper deflation, the lungs cannot fully experience a corresponding increase in pressure to cause air to flow out of the lungs. As a result, patients with obstructive pulmonary disease have difficulties with expiration.
Antigen presentation is a process of the immune system to capture, process, and present antigens to the T lymphocytes. The antigen-presenting cells involved include dendritic cells, B lymphocytes, and macrophages. In this animation, we will show how phagocytosis contributes to both antigen presentation and cytokine production. When pathogens, such as microorganisms, enter the body, phagocytes, which include macrophages, are attracted to the area of invasion by chemotaxis. After attachment to specific phagocyte surface receptors, the pathogen is engulfed into the cytoplasm within a phagosome. This phagosome fuses with lysosome vesicles containing digestive enzymes to form a combined vesicle known as a phagolysosome. Notice that the pathogens are then digested inside the phagolysosome. Let's now take a closer look at the exogenous pathway of antigen processing and presentation. Major histocompatibility class II molecules are produced in the endoplasmic reticulum of an antigen-presenting cell. As the MHC class II molecule is formed, it's transported in a vesicle. During the fusion process of these two vesicles, invariant chains are degraded, digested, and peptides take their place on the MCH class II groove. The MHC class II antigen complex is then transported to the cell surface, where it is now accessible for interaction with CD4 T cells. Now, let's focus our attention on the interaction of an antigen-presenting cell with a CD4 T cell. There are several steps involved in T cell activation. This process is initiated by the binding of naive T cell receptors to the MHC class II antigen complex of an antigen-presenting cell. This allows for the antigenic specific nature of T cell activation. Let's take a closer look. Co-stimulatory molecules, which include B7 and integrin located on the antigen-presenting cell, bind to the T cell via CD28 and IgCAM, respectively. MHC class II molecules on the macrophage bind to T cell receptors, or TCR, on the T helper cell. This is followed by CD4 binding to the MHC class II molecule. Next, B7 binds to CD28. Integrin then binds to IgCAM on the T cell. The binding of these co-stimulatory molecules provides a second signal. A third signal results from cytokines, such as interleukin-1, interleukin-6, and tumor necrosis factor, being secreted by the antigen-presenting cell into the T helper cell. These cytokines induce the proliferation and differentiation of T cells into effector cells and memory cells. Activated T cells then produce and secrete interleukin-2, which assists in the development and differentiation of CD4 T helper 1 or CD4 T helper 2 cells. T helper 1 cells produce interferon gamma. When interferon gamma interacts with macrophages, this increases their phagocytic ability and their capacity to digest pathogens. Now, let's proceed with the interaction of the CD4 T helper 2 cell with B cells. CD4 T helper 2 cells only activate those B cells that recognize the same antigen as they do. When a B cell presents a specific antigen recognized by a T helper 2 cell, the bond between the two cells is strengthened. The B cell becomes cross-linked to the T helper 2 cell. T cell receptor binds to the MHC class II peptide conjugate, which contains the antigen. Next, CD4 on the T cell binds to MHC class II on the B cell. This complex synthesizes CD40 ligand, which interacts with CD40 on the B cell surface. The final signal delivered by the T helper 2 cell is the release of cytokines into the B cell, which include interleukin-4, interleukin-5, interleukin-6, and interleukin-13. This induces the differentiation of B cells into antibody-secreting cells and memory cells. Notice the turn of events. The B cell becomes activated, followed by proliferation. And differentiation. Creation of memory cells. And then production of antibodies. Now that we have seen the illustration of the exogenous pathway, let's proceed to the endogenous pathway of antigen processing and presentation. Proteins synthesized by endogenous antigens such as viruses in the cell cytosol are routinely degraded in proteasomes. The endogenous peptides from these proteins enter the endoplasmic reticulum through a peptide transporter known as the TAP complex. In the endoplasmic reticulum, they have the opportunity to bind to freshly synthesized MHC class I molecules. The MHC class I protein complex is then transported to the cell membrane, where it can now be presented to CD8 T lymphocytes. Interaction of an antigen-presenting cell with a CD8 T cell. The interaction between a T cell receptor and the MHC class I antigen complex on the surface of the target cell is recognized by cytotoxic CD8 T lymphocytes. CD8 then binds to the complex, which consists of TCR and MHC class I antigen. This leads to an infusion of toxic granules into targeted cells. Perforin creates pores in the membrane of the target cell, which allows granzymes to enter. Granzymes later activate Cas spaces, which in turn trigger processes that lead to cell death. Congestive heart failure, or CHF, is a complex syndrome that can result from any functional cardiac disorder that impairs the filling or ejection ability of the ventricles. Congestive heart failure is present in approximately 5 million people in the United States. In this animation, we will review the pathophysiology of CHF. We will also highlight the mechanism of action of digoxin. Let's take a closer look at the heart. Take a moment to identify the various anatomical structures. We are looking at a representation of the normal function of the heart. Notice how blood leaves the ventricles with each contraction. A variety of conditions can predispose to CHF, including myocardial infarction, hypertension, valvular heart disease, cardiomyopathy, and amyloidosis. The pathologic changes caused by these conditions lead to decreased contractility and subsequently decreased cardiac output. This will cause a reduction in blood pressure. In response to the decrease in tries to compensate through the act placing further strain on the heart. Norepinephrine also acts on beta-1 receptors in the heart, increasing both its contractility and rate. Initially, this helps to maintain the cardiac output. However, in the long term, it increases the amount of work the heart has to perform. To counteract these effects of norepinephrine, beta blockers are used in the treatment of CHF. We will now review the activation of the renin-angiotensin-aldosterone system in response to reduced blood pressure. Let's take a closer look at the kidney. A decrease in blood pressure results in a reduced perfusion to the kidneys. This reduces the tension within the wall of afferent arterioles, which stimulates renin release from juxtaglomerular cells. Renin release is also stimulated by increased sympathetic activity. After its release, renin circulates through the bloodstream, where it converts angiotensinogen, synthesized by the liver, to generate angiotensin I. In the lungs, angiotensin I is converted by angiotensin converting enzyme, or ACE, into angiotensin II,
which then travels to the peripheral arterioles. Let's zoom in on a peripheral arteriole. Angiotensin II binds to its receptors in the blood vessels, causing vasoconstriction. This increases the total peripheral resistance, which in turn raises the systemic blood pressure and increases afterload. We will now review the action of angiotensin II on the adrenal gland. Let's zoom in on the adrenal gland and look more closely at the zona glomerulosa. Angiotensin II travels through the circulation to the zona glomerulosa. Here, it stimulates the synthesis and the release of aldosterone. Aldosterone then circulates through the bloodstream to the kidneys. Finally, it reaches the principal cells of collecting ducts. Here, aldosterone binds to its receptors, increasing reabsorption of sodium and the excretion of potassium. This will increase blood volume, therefore raising blood pressure. This produces fluid overload that further increases the burden on the heart. ACE inhibitors and angiotensin receptor blockers are used in the treatment of CHF since they decrease the effects of angiotensin II. Let's now summarize the effects of these compensatory processes on the heart. The increased afterload caused by the increased activity of both circulating catecholamines and the renin-angiotensin-aldosterone system amplifies the amount of work the left ventricle has to perform. In response, the left ventricle develops pressure overload hypertrophy, which is concentric. In contrast, volume overload causes ventricular dilation. This occurs in response to excess angiotensin II and aldosterone production. This myocardial remodeling leads to left ventricular failure. Since the heart is not ejecting enough blood, the end systolic volume will be abnormally elevated. This will increase the pressure within the ventricle. This increase in pressure backs up to the left atrium, then the pulmonary veins, and further to the lungs. The increased pulmonary capillary pressure favors fluid extravasation, causing pulmonary edema, which impairs ventilation. This pathogenesis explains why left-sided heart failure presents with respiratory symptoms such as cough, shortness of breath, and orthopnea. On auscultation, there will be rales and an S3 gallop due to fluid overload, illustrated here as an increase in end systolic volume in the left ventricle. To reduce fluid overload, loop diuretics can be used in the treatment of CHF. The increased back pressure in the lungs progresses to the pulmonary artery, and then to the right ventricle. The resulting increase in pulmonary vascular resistance eventually intensifies the amount of work the right ventricle must perform. This results in right ventricular failure. As the end systolic volume rises, the pressure within the right ventricle increases even further. This eventually leads to an increased pressure within the